So in this track of the conference, we are in the theme that deals with research development and innovation for a capable state. And this session in particular focuses on information and communications technology for health and education. We will have two presentations during this session. And one thing I would like to encourage to those in attendance is to please visit the conference website, have a look at the biographies of the speakers and panelists. It's truly a privilege to be in the company of such highly accomplished individuals. And before we begin, please set your cell phones on silent to avoid disruption. And without further ado, let's go to our first presentation. And the title of our first presentation is Scaling Up Primary Healthcare Telehealth Innovations in Trusted Cyberspace. Enhancing healthcare access through effective and efficient referral pathways. So this will be presented by a team that comes from different parts of the CSIR, an EPIC team, EPIC being the values of the organization, excellence, people-centered, integrity, and also collaboration. So that includes Dr. Laticha Walters, who is Senior Technologist and Digital Health Governance Advisor at the CSIR, Mr. Jeremy Wallis, Impact Area Manager of Industrial Sensors, also at the CSIR, Dr. Amanda Skepu, Impact Area Manager of Molecular Devices, also at the CSIR, and also Dr. Zubeida Dawood, who is Research Group Leader at the CSIR within the Defense and Security domain. And with that, let me hand over to Laticha, who will start us on our journey. Thank you.
Thank you, Lulama. So, in the spirit of harnessing research, development, and innovation for a robust South African economy, we are keen to present our EPIC CSIR innovations to assist the scaling up of primary healthcare telehealth in trusted cyberspace. As mentioned, we are an EPIC CSIR team, and we hail from various research groups, impact areas, and clusters. We collaborate on innovating and localizing technologies while providing knowledge solutions for the inclusive and sustainable advancement of our economy and society. We thank you for the opportunity to present our innovation of scaling up primary healthcare telehealth in trusted cyberspace. As Lulama mentioned, I'm Laticha, and I'm honored to be joined by my colleagues and fellow scientists. I will present our innovation, and the team will be responding to specific questions that our chair will coordinate. Our aim is to enhance access to healthcare services and providers by digitally and physically augmenting the effectiveness and efficiency of the referral pathway, particularly in under-resourced healthcare settings. Innovations that are at scale-up readiness state for implementation locally, regionally, continentally, and globally. So, we would like to share a few definitions. Really, our objectives really are, as mentioned, and we will talk about a few definitions, talk a bit about the background and need for telehealth. We will explain our value proposition. We'll share our research, development, and innovation. It's a culmination of at least 4 to 6 innovations that you will be seeing today, and our business model. There are various terms for telehealth, such as telemedicine, digital health, and even virtual health. The WHO, the World Health Organization, defines telehealth as the provision of healthcare at the distance with the use of ICT. And if anything, we've seen that come into play and into the forefront during our COVID-19 pandemic. Unfortunately, the majority of our population could not benefit from that service. There are different types, provider to provider, teledermatology, provider to patient, such as telepsychiatry, and then there are also some patient to provider and some hybrid models. You can have it either through a synchronous, you are directly online and you can engage, or asynchronous, so it might even be a recording or a message that gets sent and the response is provided at the later stage. Our antenatal services relate to medical care given to pregnant women before their babies are born, and you will see why later. Point of care, we have some point of care innovations that can be used at our primary healthcare level. Our cybersecurity is essentially information security innovations to secure our connections and the data that we share and transmit over the internet. So, in terms of the telehealth background and need, there is a scarcity of healthcare providers, for example, one dermatologist to serve 310,000 people. Interesting how the skin is our largest organ and that a skin condition is normally one of the first signs of an underlying disease. So just as an example, as this relates to teledermatology, where our research emanated, this trend is similar for most of our healthcare providers, especially on our primary healthcare antenatal service level. So telehealth is not new. It's been around in South Africa and actually started with the national telehealth system way back in 1999. So that's about 23 years. And the question would be, oh, wow, so why are we still having this at the conference? All these developments need to be in alignment with the referral policy for South African healthcare services, a national digital health strategy, our national development plan, our national health insurance bill as it stands, and towards reaching Sustainable Development Goal 3, which is a healthy life for all of us. The good news, though, is that one of the positive outcomes of our COVID-19 pandemic is that our telehealth guidelines were revised. So pre-COVID, there were a number of barriers, of which regulation was one of the main ones. And now it's legalized that pre-COVID, you couldn't provide a healthcare service to a patient that you do not have a pre-existing relationship. Whereas in COVID, there's no time to wonder whether I've seen you or not. And so there was a need, and our regulations have been amended, and we're super, super happy about that. The telehealth value proposition is all around the referral pathways. So, for example, in our antenatal care and for all other referrals, you would start at primary healthcare level, you would be referred to our district or regional level, and central and academic level. Quite a bit of time lag, and there are specific reasons for that, and one of them obviously is the scarcity of our healthcare providers. So the question is then, how can telehealth and what can telehealth bring to the table? And it's proven that telehealth can reduce referral rates up to 75%. That's huge. That means you can now receive the service that you require at your nearest point of access, wherever that may be it primary, district, or even on a central level. So, the term scale-up has been defined by the World Health Organization as deliberate efforts. So it doesn't just happen. Deliberate efforts to increase the impact of successfully tested health innovations to benefit more people and to foster policy and program development. So the doctor could essentially see all our expected women, but the need for a scale-up framework and a roadmap in order to take us from this pilot, they almost call it like pilotitis, where we sort of stuck since 1999, to bring us into the now. To address the identified needs, we developed a scale-up framework. And the first step is to ensure that you have a mandate from the digital health strategic objectives and budgets. Obviously, you need to have that mandate. And then you need to have some basic building blocks in place. All of this runs along a continuum from ad hoc, formalized, realized. And depending where you fall on the continuum, you would see ad hoc, it's pretty much you are here. You might have moved on a little bit here, but you're not in scale up. Ideally, that's where we want to aim, and we want to sustain whatever we've put in place, that it doesn't fall over post-pandemic, and now it just disappears. All of this are driven along by some drivers. We've also developed a roadmap which forms the second part of our telehealth innovation by providing a guided approach based on where you are. It's very context specific. Some sites might be further along in some areas than others, so it's not a one-size-fits-all, and our roadmap would be able to guide us. So Mr. Jeremy Wallis leads the research, development and innovation of our scale-up ready AmbiFlow innovation, and will be taking the questions in this regard. Some of you, or most of you, might even be aware and familiar with our AmbiFlow innovation. It was subject to extensive clinical trials through the University of Pretoria in order to evaluate its impact on antenatal care practices. In the Tshwane trial, it was tested in Mamelodi, Bronkhortspruit clinics and found to reduce the stillbirth rate with up to 50%. This led to a national 9-province trial where it was tested in every province and similar impact was observed. The World Health Organization funded a study in Rwanda, Ghana, Kenya, and India with similar results being recorded. Our AmbiFlow has been licensed to a South African medical device manufacturer who is busy with securing a CE mark for it, which is a regulatory prerequisite for its sale in South Africa and globally. AmbiFlow's integration into telehealth can be tested and will be tested in a rollout to up to 70 clinics in and around Tshwane. Our next innovation is Dr. Amanda Skepu, and she heads up our research, development and innovation for our commercialization-ready lateral flow and isothermal point-of-care innovations, and will be taking the questions in that regard. Our lateral flow point-of-care rapid test kits are used for antenatal care screening. So firstly, when a lady suspects that she might be pregnant, that would be one of the first tests that can be conducted, and this is at clinic level. So no more sending blood test or expensive handheld test. Once the pregnancy is identified, she can be tested during her first trimester for HIV and thyroid stimulating hormone, which if it's not detected early after birth and is not treated, can potentially result in baby retardation. It can also detect food pathogens that are risky to our pregnant ladies and the baby, such as salmonella. Additional tests are listeria and toxoplasma, which is what we do not want to have. So another innovation is our isothermal point-of-care molecular tests. So these tests are more from a confirmatory. So once the lateral shows a positive results, we use our molecular PCR tests. They work more on a DNA level, and our first tests work on a protein level. The two technologies complement each other, and we're super, super happy to be working with Dr. Skepu and her team. Dr. Zubeida Dawood leads the research, development and innovation of our commercialization-ready cybersecurity innovations, and will be taking questions in that regard. So healthcare organizations such as our clinics and our healthcare levels from primary to provincial to national level are all vulnerable and targeted by cyber attacks because they have personal information that is highly valuable and growing as we speak. It was interesting, just an anecdote, we had a session with the Department of Health and they mentioned that digital health data has become the new blood. So we need to secure it. This includes patient-protected health information, personally identifiable information, such as identification numbers, financial information, banking details, etc. While we want digitalization and we want to scale up telehealth, we must manage our risks actively. Our network emulation simulation laboratory provides a platform for high-fidelity replication of existing or planned networks through a mixture of physical and virtual devices. The solution ensures the reliable testing of concepts and products before deployment in an operational environment. And a key thing, and if our Dr. Blade Nzimande would be happy to hear, that it can also be used for training our future scientists and our future cybersecurity group gurus. Our biometric systems are used mainly to authenticate a person at healthcare facility level, such as antenatal clinics. So, if we look at our the framework that we've developed and all these super cool innovations, how does it come together and how does it really work? So firstly, we will assess where you are. So typically, if we start with the ad hoc, we would find that our AmbiFlow, we would be able, the lady suspects she might be pregnant. So she comes in, and firstly, we would do some blood tests. We will do the screening, the lateral flow, and we will use the PCR to confirm. What you can see, the next thing is we would start tracking her pregnancy on our AmbiFlow. But what you can see here is that these systems are very much standalone. There might or might not be some sort of a health record system going, and in most instances it's not, and we might have manual records. And so it's pretty much standalone. There's some connectivity to our national level where, in terms of aggregate data that get rolled up, but that's really what it is. And that qualifies it for the ad hoc, not much integration. So she, now her pregnancy is confirmed, and family's happy, we're all happy. But now she visits family, and in a little bit in the district, there's a family event, and she experiences some discomfort, and her family takes her to the nearest district hospital. It's like one of those adverts. What will happen? Nothing. Or I shouldn't say nothing, but not much. So what has happened here, her records is physically lying on primary healthcare level. Her data is lying on primary healthcare level. And they basically have to start from scratch and rely on her to give her own history as she can best account for it. So, our next step is formalized, where we started with our scale-up process. So now what was living on primary healthcare level is now available on provincial level as well. So now when Our Lady presents herself, and they are able to continue test and at least start tracking in terms of her AmbiFlow history and in terms of her point of care tests to see if additional tests, she might have picked up some food pathogens, Dr. Skepu, and they would be able to track that. And at this level, what we find is that digital transformation of our manual records have started, but we pretty much still aggregate. So they're not really able to fully track her medical history. Next, on the realized state, where the connected systems are enhanced with integration and fully interoperable with our point-of-care innovation, and our digital transformation of our medical records are now complete, and our cybersecurity are in full force. We are able to track it through our Nestle system, where we, if expansion needs to happen, we can use the Nestle tools to simulate before we just go about wildly and expand systems, and not taking care of securing our data flows. And then also physical biometric systems can be implemented on the various levels now, just not on the primary healthcare level, but also rolled out to other levels where needed. So now Our Lady can receive relevant antenatal care at all levels, and clinicians have access to all the previous test results and a medical history. So the doctor can provide anti-care now. Managed care system, managed care system are now ubiquitous. We don't care what system the clinician is not faced with what system I'm using. I'm using one system, and it's able to provide me with the medical history of my patient, irrespective of where she lives, where she resides, or even if she's just visiting at this specific point of care. And that's the strength of scaling up telehealth. So our digital health ecosystems are now fully interoperable at this level and in full alignment with our referral policies. Typical TELUP scale-up roadmap implementation, and this is context sensitive, can take anything from the pre-scale from 6 months to 1.5 years, or scale up between 1 to 3 years, once again depending on their readiness, or post-scale up between 6 to a year. So one of the lessons we've learned from COVID is the time to enhance virtual access to care at the nearest point of access is now. So our private healthcare made some strides, but we in the public health need to make sure we take care and provide care where it is needed. South Africa has been piloting telehealth for the last 23 years, but we have not been able to scale up to meet the needs of its people. Scaling up telehealth in trusted cyberspace with integrated point-of-care technologies solve the access to limited number of healthcare professionals and thus reduce referrals from primary healthcare to higher levels of care with up to 75%. Our business model would be to identify scale-up ready sites and work with them. We are speaking and we are in talks with Auda Nepa through the Center of Excellence, Science and Innovations of we ourselves and Stellenbosch are founding members, and we're super excited. So in the spirit of harnessing research, development and innovation for a robust South African and continental economy, we are ready to assist with the scaling up of primary health care. So to recap, our aim, which is to enhance access to healthcare services and providers, we have demonstrated how our antenatal care can be provisioned by digitally and physically augmenting effectiveness and efficiency of our referral pathways, particularly in under-resourced healthcare settings. Our innovations are scale-up ready. They are scale-up ready both locally, regionally, and globally. The CSIR is ready to sustainably scale up healthcare level telehealth in trusted cyberspace. We would like to invite you, if and any other potential partners, innovators, funders, agency to approach us to join us in our scale-up journey. I thank you.